Thank you for nice introduction, Dr. Gayatri. Good morning, dear friends, respected seniors and colleagues. At the outset, I would like to thank organizers of this wonderful conference, Dr. Radha Lakshmi ma'am and Dr. Venkatramana sir. So my topic today is diagnosis and management of fetal growth restriction. Actually, this is a very vast topic, but I will finish in 31 minutes. So, you should know some terms related to growth. AGA, that is appropriate for gestational age, means where the estimated fetal weight is between 10th to 90th centile. SGA, small for gestation, when the estimated fetal weight is below 10th centile. LGA, large for gestational, when the estimated fetal weight is more than 90th centile. And macrosomia, this word is used when there is specific cutoff like 4 kg or 4.5 kg. So up till now, we have been using these words IUGR, intrauterine growth retardation, symmetric IUGR, asymmetric IUGR, but nowadays we don't use these words. We use FGR, that is fetal growth restriction, which could be either early or late. So what is the definition? Fetus that has failed to achieve its genetically determined growth potential is called as FGR. But since this growth potential cannot be judged by any way, so we use fetal size as a proxy with all its limitations. So the correct definition is a fetus with estimated fetal weight less than 10 centile on ultrasound because of pathological process has not attained its biologically determined growth potential. So why are we worried about this? Because it is associated with increased perinatal morbidity and mortality, associated with long-term adverse infant outcome, associated with increased risk of non-communicable diseases in adulthood like hypertension, diabetes mellitus, coronary artery disease, and so on. And in India, it has got a very big chunk. Almost 30% babies are SGA, small fetuses. So the most important 4 prerequisites or 4 pillars when we discuss FGR are dating, biometry, growth charts, and Doppler. Correct dating will give correct diagnosis of FGR. If your dating is not correct, you will misdiagnose FGR. So 4 important basic points in dating are: go for CRL till 13 weeks 6 days. After that, go for HC and or FL. Once assigned, don't change in subsequent scan. EDD is only one, not multiple EDDs. And always ask for dating scan when the patient comes later in pregnancy to correct the dating. Biometry, BPD, head circumference, abdomen circumference, and femur length. We all do in your day-to-day practice because correct biometry will give you correct estimated fetal weight. All formulas are having these constituents. Where FGR stands, we discuss much more about trisomies, aneuploidies, and all those things. See the prevalence and compare with this tall building of FGR. So FGR needs more attention. Some important aspects about growth. Growth and size are not the same. Growth implies velocity, that is change in size with time. So it can be assessed only by longitudinal measurements, and so use growth charts in your practice routinely. Again, this is a very nice paper from Netherlands. Fetal smallness is not the absolute marker for adverse parental outcome. You can see here the highest mortality is seen when the estimated fetal weight is less than 3rd centile. Here, this is the big thing. And lowest when the weight is between 90th to 95th centile. But see this area. The estimated fetal weight between 10th centile and 50th centile. This is not immune either. There is significant parental mortality in this area, so this area also needs more attention. Yeah, this is another paper by Leon Apun, birth weight with gestational and maternal characteristics in live births and stillbirths. So majority of preterm stillbirths are SGA, small for gestation. Yeah, it is accepted, everyone knows it. But majority of term stillbirths are not SGA. Many of them are AGA. In fact, more than 60 to 70% of term stillbirths are because of late FGR, which were falsely labeled as unexplained deaths in previous years. So you need to define the difference between SGA and FGR. So SGA is easy to define. It is a statistical deviation from normal. Any fetus with estimated fetal weight less than 10 centile, you can label it as SGA. Is every small fetus is FGR? Can you compare Sunil Gavaskar with Joel Gardner, or these two things, these two players? No, the answer is no, because many are constitutionally small. Almost more than 70% small fetuses are constitutionally small. Many are because of chromosomal or genetic anomalies, because of infections, and many are because of uteroplacental deficiency, and this is the area we are discussing today. So are all small for gestational fetuses FGR? The answer is no, because there are many which are constitutionally small. Again, are all FGR fetuses SGA? The answer is again no, because in late FGR you may get many fetuses which are appropriate for gestational age, which fall between 10 to 50th centile. So FGR have two subsets of the patients. It can be SGA, small for gestational age, or it can be AGA, that is appropriate for gestational age. So 32 weeks is the cutoff to define difference between the early onset and FGR. When the gestational age at diagnosis is less than 32 weeks, we label it as early onset FGR. When it is more than 32 weeks, we label it as late onset FGR. A quick review of Doppler indices. Out of these RI, PI and SD ratio, we use only pulsatility index because it shows linear correlation with vascular resistance, and it doesn't reach infinity when diastolic flow is 0. So umbilical and uterine artery Doppler, these are placental tests because they reflect fetoplacental and uteroplacental impedance, and fetal MCA, middle cerebral artery, and ductus venosus, these are fetal tests. They indicate response to adversity. So coming to uterine artery, it tells you about the uteroplacental circulation, maternal compartment. As the pregnancy advances, the resistance goes on decreasing, diastolic flow goes on increasing, PI value drops. These are the cutoffs for first trimester and second trimester, but instead of talking in terms of cutoffs, always use the language of centiles. This value falls on this and this centile for that gestation age. For all obstetrics parameters, use language of centiles only. And high uterine artery PI, mean uterine artery PI, when it is more than 95th centile, it is a risk factor for fetal growth restriction. Next is umbilical artery. It tells you about fetoplacental circulation, that is fetal compartment. Normally, it tells you about placental resistance. When the gestation goes advances in gestation age, the diastolic flow goes on increasing, PI value goes on decreasing, and abnormalities are detected in terms of high PI, absent diastolic flow, and reverse end diastolic flow. So this is very important to know the 30-70 concept, the basic difference between early onset and late FGR, late onset FGR. So when the placental damage is more than 30%, as shown here, the umbilical artery Doppler is always abnormal because the resistance is high. So this happens in early onset FGR. But this is not in case of late onset FGR. In late onset FGR, the placental damage is less than 30%. So umbilical artery Doppler is normal here for initial period of development till 30 weeks, 31 weeks, 32 weeks. This much placenta is sufficient for growth of the baby, but after that this much placenta is not sufficient and the baby start growth retarding, and this is the concept of late onset FGR. So you may get AGA fetus at 32 weeks, but it may land in fetal growth restriction at 36 weeks. So clinical application of umbilical artery Doppler, it is good surveillance tool in FGR. It precedes CTG changes in 90% of cases, but it fails to identify late FGR cases because it is normal in most of the late FGR cases. Also, it is important to observe the trend of umbilical artery Doppler. Even though it is in normal limits, if the trend is increasing, you need to worry and put the fetus under surveillance. Next is middle cerebral artery. It is indicator of fetal hypoxia. Normally, it has biphasic wave. Normally, it is having a high resistance flow, but in response to hypoxia, there is centralization. It is called as brain sparing effect. More blood flow is drained to fetal brain, diastolic flow is increased, and the MCA PI go on decreasing. Cerebroplacental ratio, it needs mention here. It is the ratio of MCA PI to PI of umbilical artery. It becomes abnormal before MCA. It is more sensitive than MCA. MCA is more specific for fetal hypoxia. Ductus venosus, this is small trumpet-shaped vessel connecting umbilical vein to fetal heart. Normally it is triphasic, SD and A wave. As the gestation advances, the diastolic flow goes on increasing, so PI values goes on decreasing, and it is a marker of fetal myocardium, fetal heart. Whenever there is problem with fetal heart start failing, there are problems with ductus venosus, and that can be reflected in terms of high PI, absent A wave and reverse A wave. Aortic stemnus, again this is not routinely used, but reversal of flow in aortic isthmus precedes DVA wave reversal by 1 week, and it is indicative of poor neurological outcome in those fetuses. So this is a new thing published in Journal of Clinical Medicine in 2023 about fetal tibial artery Doppler. It tests that alteration in fetal tibial artery are detected earlier in comparison with other Dopplers which we are using currently, but this needs more research and attention. So here is the difference between SGA and FGR. In SGA, there are no Doppler signs of adaptation. The cause is not known. Most of them are constitutional, and you can prolong the pregnancy up to term, and outcome is normal, perinatal outcome is normal. But this doesn't mean that you should left alone these fetuses. These fetuses should be kept under good surveillance. And this is not in FGR. There are Doppler signs of adaptation, placental insufficiency is there, and you cannot prolong pregnancy beyond 37 weeks, and there is risk of intrauterine fetal death. So whenever there is estimated fetal weight between 3rd centile and 10th centile with no other Doppler abnormalities, you can label straightaway this as SGA baby. So this is the definition. Delphi consensus for early onset FGR. There are two types of criteria, solitary criteria and contributory criteria. In solitary criteria, there are two things. Either of them you can label it as early onset FGR. When there is AC, abdominal circumference, or estimated fetal weight less than 3rd centile, or severe umbilical abnormality like absent endostelic flow, you can label straightaway as early onset FGR. In contributory criteria, there are three things. 2 out of 3 you can label it as contributory criteria when abdominal circumference or estimated fetal weight is below 10 centile with either Doppler abnormality in uterine artery or umbilical artery as more than 95th centile. Again, coming to late onset FGR, there is solitary criteria. There is only one solitary criteria, that is when the AC or estimated fetal weight less than 3rd centile. Umbilical artery cannot be taken here because in most of cases of late FGR, umbilical artery is normal. And in contributory criteria, there are 3 things. At least 2 out of 3 should be sufficient to label it as late onset FGR. When the AC or estimated fetal weight less than 10 centile with Doppler abnormality in uterine artery like more than 95th centile and CP ratio less than 5th centile, or AC or estimated fetal weight crossing 2 quartiles. 2 quartiles means they are dipping by 50th centile. Initially, the estimated fetal weight was on 85th centile, and on second occasion we are looking, it is going below 30th centile. So you can label this as late FGR even though it is more than 10 centile, it is AGA fetus. And this is the mystery of late FGR. So this is the difference. In early FGR, the problem is management. Diagnosis is not difficult because we are dealing with this patient in our day-to-day practice. Fetal size is small, placental disease is high, umbilical artery is abnormal in most of cases, associated preeclampsia is more, hypoxia is more, but tolerance to hypoxia is less, is very good. While in late FGR, diagnosis is difficult. If you don't do multivessel Doppler growth scan at 35-36 weeks, you cannot diagnose late FGR cases. Placental disease is mild, umbilical artery is normal, preeclampsia association is very, very low, hypoxia is not very much, but susceptibility to hypoxia of the fetal brainstem is more, and that is the problem with late FGR fetuses. Now coming to management, there are 3 key concepts about management. One is placenta playing double role, cardiovascular adaptation versus brainstem suppression, and hypoxic threshold versus lung maturity. So placenta here plays 2 roles. One is as a nutritional organ and another as a respiratory organ. You can see this chart. This green line tells you about the nutritional requirement of the baby, and it starts rising from early gestation. So we use this as a nutritional capacity of placenta to detect fetal growth prediction. Is the baby growing well? We plot it on growth charts and diagnose SGA, AGA, and all other things. While you see this red line, this is the respiratory capacity of the placenta. It starts rising after 30 weeks, and it tells you about the oxygen exchange across the placenta. Is the baby hypoxic? Is the baby acidotic? And when to deliver? And it tells you about the trigger for delivery in late FGR cases. Next thing is cardiovascular adaptation. In early FGR, the placental disease is severe, so there is high resistance, umbilical artery resistance is high, so heart need to work more and more against this high resistance, so eventually it fails, and that is reflected in the form of abnormal ductus venosus. And this is not in case of late onset FGR, because the placental disease is very, very less than 30%, so umbilical rate is normal, umbilical artery is normal, heart is happy, so DV is not affected in late FGR cases. So what are the tools to detect cardiovascular adaptation? Doppler, umbilical artery Doppler, precordial vessels like ductus venosus, and new thing, computerized CTG. It is not available with each and every one, but your routine NST which we use in your clinical practice, this is also used, can detect this cardiovascular adaptation. So next is brainstem suppression and variable susceptibility. The immature brainstem is resistant to hypoxia. The brainstem at around 26-28 weeks is not so much susceptible to hypoxia, but when the term brainstem, you consider term brainstem, it is highly metabolically very, very active, so it is highly susceptible for hypoxia. Even slight drop in oxygen saturation will affect it, it will suppress it, and when brainstem is suppressed, the heart stops. It can be compared with Sherpas and routine people. Sherpas are very used to go to high altitudes without any problem. It is daily routine for them. But common people like us, even when we go to base camps, we are facing the troubles. So in early onset FGR, heart, that is ductus venosus, is at stake, and in late onset FGR, fetal brain, that is brainstem, is at stake. So what are the tools to detect brainstem suppression? These are biophysical profile, CTG, and DFMC, daily fetal movement count. The third thing is hypoxia versus lung maturity. We want to keep the baby as long as in the womb for the betterment, but there is fetal hypoxia. If you keep baby for more time, there is risk of fetal death. And another thing, if we take out earlier, there is risk of prematurity. So management depends on the balance between these two. So 32 weeks is very important landmark when we are discussing management of fetal growth restriction. We wait for acidemia before 32 weeks because the lung maturity is not there. After 32 weeks, we deliver for severe hypoxia. That is, we look at umbilical artery changes. Aortic isthmus, it is associated with poor neurological outcome. It is in between 30 to 34 weeks, but still it is under research. It is not used routinely in our clinical practice. So what are the tools of surveillance? These are Doppler, biophysical profile, NST including NST, amniotic fluid, and daily fetal movement count. So what are the markers of prognosis? Umbilical artery, ductus venosus, and peri-aortic isthmus. So umbilical artery, severe forms are used to trigger delivery. When 60% placental damage is there, it is associated with absent end-diastolic flow. It indicates severe hypoxia. Reverse end-diastolic flow tells you about 70% placental damage. It tells you about suspicion of acidosis. So you should know something about fetal circulation. It runs parallel with 3 shunts. Right ventricle output is separate from left ventricle output. Right ventricle output depends on subdiaphragmatic vessels and placental resistance, while left ventricle output depends on resistance in brachiocephalic vessels, head neck vessels. So in FGR, what happens? Placental resistance increases and cerebral resistance drops, so right heart fails first, followed by left heart. And when right heart fails, everything comes on ductus venosus. It is reflected by high PI, then absent A wave, then reverse A wave. So trigger for delivery in early onset FGR is acidosis before 32 weeks, and this is not in case of late FGR or term FGR because heart is happy in these cases. So what about MCA and CP ratio in early onset FGR? In early onset FGR, placental disease is severe. MCA is always compensated, but it has not got any clinical utility. Delivery entirely dependent on ductus venosus flow or abnormal umbilical artery flow. In late FGR, MCA is predictive of adverse outcome, but becomes abnormal very late. It cannot be used for surveillance. We use cerebroplacental ratio for surveillance in late FGR cases. This is a very famous OROS chart. It tells you about the sensitivity of all these Dopplers to fetal hypoxia. You can see the umbilical artery and uterine artery, they are linear, they are in straight line, they don't show any change. But if you see the MCA and CP ratio, they are deflecting, they are going downwards, and if you see more carefully, the MCA starts dropping after 36 weeks, while CP ratio starts dropping after 31 weeks. This confirms that the sensitivity of CP ratio is more than MCA to detect as a sensitive marker for fetal hypoxia. Cerebral Doppler MCA is not used for surveillance either in early or late. CPR can be used for late FGR only. Now coming to biophysical profile, it has 4 acute constituents along with chronic marker, that is amniotic fluid, non-stress test, breathing movement, fetal tone and fetal movement. So CTG tells you about the fetal rate, heart rate variability with acceleration with movements. Non-reactive fetal CTG tells you about good brainstem. The brainstem is not hit by hypoxia. You can see fetal breathing movements on ultrasonography. If NST is normal, fetal breathings are normal, you need to go beyond that. You need not go for fetal movements and tone. These 2 things are sufficient to tell that there is no hypoxia. So this is very important differences in gestational age. In early onset FGR, fetal heart rate abnormality, that is CTG changes, happens after umbilical artery abnormality. It coincides with ductus venosus abnormality. So this is seen in late cases. While in late FGR, fetal heart rate abnormalities occur before Doppler changes can occur. So CTG is very, very important in late FGR because brainstem is more susceptible to hypoxia. Again, our interested thing, DFMC, daily fetal movement count. This is a very nice article published in American Journal of Obstetrics and Gynecology. What does it tell? 55% of women experience it before stillbirth. Majority are preceded by 3 to 4 days. There is no fixed pattern of telling history by the patient. Every fetus is having its own pattern. But when patient is coming more than one time to you that my baby is not moving, you should be alert. You should not neglect these complaints. Next is amniotic fluid. We are very much worried about amniotic fluid as an obstetrician, but there is no role of amniotic fluid in management of fetal growth restriction because it doesn't tell about hypoxia, acidosis, frequency of surveillance or trigger. It is just a marker of chronic hypoxia. Less blood supply to kidneys, less urine output, and low liquor. In a study, it has shown that when the diagnosis of FGR made, the amniotic fluid was stable for 8 weeks. This tells you that it cannot be used for management of fetal growth restriction. So tools for early onset FGR are Doppler, umbilical artery and ductus venosus, and CTG, which can be used as safety net. While in late onset FGR, you can use Doppler, specifically CP ratio, CTG, breathing movements, and daily fetal movement count. So what happens in early FGR? Placental disease is very, very high. So there is abnormal umbilical artery, abnormal MCAPI, umbilical artery becomes end diastolic flow, then reverse end diastolic flow, ductus venosus is affected, then there is a reverse A wave, then there are changes in CTG, changes in biophysical profile, CTG decelerations, and fetal death occurs. This is the cascade of events which is seen in early onset FGR, and depending on that, the staging is done by Frigoris and Gretakos in 2014. It is divided into 4 stages, stage 1, 2, 3, 4, depending on the amount of placental injury. So stage 1 is severe smallness or mild placental disease when the estimated fetal weight is less than 3rd centile along with Doppler abnormalities. Important to remember that ductus venosus is normal here in these cases, and all late onset FGR comes under this category. In stage 2, the placental disease is severe. There is absent end diastolic flow in umbilical artery and reversal flow in aortic isthmus. Again, ductus venosus is normal here. Stage 3 is low suspicion of acidosis. There is reverse end diastolic flow in umbilical artery, or DVPI may show a high value, more than 95th percentile. And stage 4 is high suspicion of acidosis. There is reversal of flow in A wave, reversal of A wave in ductus venosus, and CTG shows decelerations, abnormal CTG. So this tells you about the stage-based classification and amount of surveillance. In stage 1, weekly surveillance with labor induction at 37 weeks. Remember, it is induction of labor, not cesarean section. In stage 2, bi-weekly with cesarean section at 34 weeks. In stage 3, look every 1 day or alternate day, cesarean section at 30 weeks. And high suspicion of acidosis, stage 4, you have to look 2 times a day, and cesarean section at 10 to 6 weeks. So, but what happens in late FGR? The mild placental injury is very, very mild. Umbilical artery is normal, but middle cerebral artery is problematic. CP ratio goes down. There are changes in CTG, and because of high sensitivity of brainstem, the baby dies suddenly. But this all happens after 38 weeks, and why it is called as diagnosis is difficult, but management is good. Just 3 minutes. So best policy is, if you deliver all the babies at 38 weeks, it reduces overall stillbirth by 50%. But what about preterm late FGR delivery? Again, go for CPR, CTG, breathing movements, and fetal movements. So what are the surveillance tools in late onset FGR? Weekly once Doppler, weekly CTG, give attention to failing CPR or MCA, increase frequency of surveillance, and don't ignore what mother says. So late principles of management in late FGR are The brain is susceptible to hypoxia, remember this. Doppler is your guide to decide frequency of surveillance, and CTG is your trigger for delivery. What about AGA group? Again same. It is managed like late FGR, weekly surveillance, CPR, CTG, deliver at 32 weeks, and this paper focused on this area, the estimated fetal weight between 10th and 50th centile, and when it is CPR is abnormal, you have to deliver at 38 weeks, and induce at term and not LSTS. And this is the last slide. Forget about FGR, forget about type of FGR, forget about staging. These are FIGO guidelines for delivery. Whenever there is abnormal BPP, decelerations on CTG, severe preeclampsia, ductus venosus reversal. If you get any of these four, you have to deliver the baby irrespective of the staging and type of FGR. So to conclude, dating, charts, biometry, and Doppler, these are four important pillars of FGR detection and discussion. More than 50% of near-term stillbirths are because of late FGR. So growth scan at 32 weeks and at 36 weeks are increased justified. Trigger for delivery in early FGR is abnormal ductus venosus, while trigger for delivery in late FGR is abnormal CTG. Thank you. Thanks for Dr. Bimal Sahni sir and Dr. Vijay for helping me creating this talk. Thank you. Thank you for your attention.